Fantastic. All right. We will we'll get our closer here. Dr. Donner is going to talk about his experience with regenerative medicine, the treatment of athletes, and this is as we've already kind of seen earlier. This is just such a rapidly expanding area of orthopedic surgery and spine surgery, and I think Dr. Donner is on the forefront of this. And let's let him tell us where he's at. So, Jeff, take it away. Thank you.
Thank you. And I'd like to thank my colleagues for the prelude to my presentation. This is the title that was given to me, and if it falls in line with my interests. I'm going to take this a little bit out of order, and I'd like to present a case to start. And this case is a 15-year-old male, right-handed multi-sport athlete who developed progressive pain in the elbow and progressive swelling over the last part of that 2 years. He eventually saw a orthopedic surgeon who aspirated the joint for this yellow fluid and then immobilized him to rest the joint in a cast for about 6 weeks. The cast was removed and the joint was very stiff and sore, and it was really difficult to obtain range of motion. With that, he went on to see another orthopedic surgeon at the university and was able to gain some motion with split cast and progressive stretching, but overall lost about 50% range of motion. Fast forward 50 years and a CT scan of what that elbow joint looks like now, you can see even though there was not a traumatic injury, but essentially an overuse to the joint, it led to an inflammatory response, and over time destroyed the joint. And this is, a very important start to this presentation, because as part of my disclosures, that is my elbow, and that was me when I was a teenager. So this has led to a lot of my earlier interest in this than maybe others, because I've had a variety of other orthopedic or musculoskeletal problems and was very frustrated with the limited ability to help reverse this problem or potentially avert it to begin with. And as you can see with my disclosures, I do have some conflicts, and I'll move through this, but part of this process that led me to developing new technologies and doing research. Because of that interest, we built out a lab, and I had some scientists there, Ryan Dragala. He still works with us on the side, but mostly has moved on to other projects, and his assistants, Jessica Herrera. Anyway, we have a suite downstairs that we created so that we can do procedures under fluoroscopy. And we also have a sterile hood where we can prepare the product and not have to use a commercially available product, which allows us some latitude in developing better technology, which is our goal. And this is the problem. And these are the resources I really want to express. There's plenty of them. If you search regenerative medicine, you'll find there's probably hundreds of related journals, and there's lectures and presentations and manuscripts in the tens of thousands, probably hundreds of thousands. But you need to kind of find your main source. And I believe that the Biologic Association is very worthy, and it's free. You can sign up and listen to their archives or their live sessions. Also, this new journal called Biologic Orthopedics is where we presented our new manuscript on our BMAX technology that I'll get into. Those of us who are orthopedic surgeons, the AAOS has taken a bigger initiative in educating us and keeping us abreast of this new area of orthopedics. Unfortunately, it was in the hands of what I would hate to say, but fringe physicians or people who actually treat this outside of being medicine, which is going to be a problem and has to be addressed. But if we take the lead, just like we have in SI joint problems, I think we'll see progress. One of the other things I want to identify is our colleagues in other areas like the pain management. And I was at the American Society for Pain and Neuroscience meeting in Miami last summer. And one of their first opening presentations sections was on the neuroimmune interactions in pain. And some of the authors were there and they presented, and I was just totally fascinated. And it really put things together for me in terms of what's going on with our patients, because pain is obviously one of the main reasons that people come to our office. And that's something that we need to realize is our main goal of treating them, in addition to preventing progression of tissue and joint damage. So we have lots of choices, as we have seen, and they all have their place and time. And at this point, we've heard about quite a few of these. I'm going to focus more on the regenerative therapies, and specifically the mesenchymal stem/stromal cells we call MSCs. And what is regenerative medicine? That's great. There's lots of definitions, but I think this is one that comes out of the regulatory people. And basically, there's a variety of therapies that seek to repair, replace, and restore function to damaged cells, tissues, or organs, and try to solve unmet needs, untreatable conditions. And that's a very worthy cause, because as we're all clinicians, we see these problems and we try to figure out, well, what do we do with them? And of course, it's based on our education. Of course, we also use our colleagues, go to meetings, read books and journals, but we also can go into the research side, and we can do bench work, we can do clinic work, and we can do animal work. And sometimes we're moving back and forth between all those, and that's what we call ourselves, and I believe I'm one of them, translational scientists. So with that, I want to kind of deal with what I think is necessary. Where's the controversy? There's a lot of people who have the belief that this regenerative medicine space is being oversold and using wrong terminology, and stem cell is certainly one of those. And I have a lot of respect for some of these people, like Farsh here on the left, who's typically at meetings I go to in Vail, called the Vail Scientific Summit, which I feel is a very good meeting if you're interested in this. And I pretty much go every year when I can. But basically, as much as he is a scientist, they see stem cells as a really unique type of cells, and they don't believe what we're doing is really stem cells. And that controversy is ongoing. But if you look at high-level institutions like the Mayo Clinic, I mean, they'll use the word stem cells very freely, and they have a very diverse group of musculoskeletal regenerative scientists. So instead of like getting into the discussion of what a stem cell is, I think I'll use the term MSC from now on. That way it doesn't offend anybody. And I don't say that it's a stem cell when we could be calling it a stromal cell or a medicinal signaling cell. And basically it has characteristics that it can differentiate into other musculoskeletal type of cell types, as you can see, chondrocytes, myocytes, adipocytes, and heal tissues, and also has a strong immune modulatory function, which is very important, because when you see these injuries that we have every day, I mean, every time you overstress a joint or a tissue, there's going to be some type of reaction to your body. And this is how this happens over hours and days. And typically, that is determined by the immune system identifying damage-associated molecular patterns in these tissues. And it's doing its job to clean it up, whether it's from a pathogen or if it's just from wear and tear or a joint injury like sports injuries. But that normal resolution doesn't always occur. And when that doesn't occur, like you see on the right, there's like a cytokine storm, like you saw with COVID, and that just keeps going and destroying the tissues and causing inflammation and pain, very much like the elbow of mine that you saw. So what actually is going on? Well, Woody's going to explain this slide, but I'll just make the brief point before he gets into the details. But as you can see, every cell has receptors, and it's listening to messenger molecules. And these messenger molecules can be good biology or they can be bad biology. And so what happens when they approach a cell, as you can see that MSC cell on the right-hand lower corner is releasing all these messenger molecules, which are like cytokines and interleukins and all sorts of growth factors. And they're having an effect on these cells and how the genes are regulated and how they proliferate. So they can either be in a positive trophic effect, or they could be in a type of process where they actually die off as apoptosis. So we need to keep that in mind. We need to send the right signals. And these signals can affect not only the joints, as you can see on the right-hand side, where this process breaks down the cartilage. And there's a very strong communication from the synovium, the cartilage, and the subchondral bone. It's really an organ, and it's very complex interaction between all those, and also the blood supply that's coming there is being influenced by even your gut. So with all that going on, there's also the same process that the nerve endings are sensing. And that process is going to lead to pain in most occasions. So if we can modulate the destruction of the joint and get it to heal, and also dial down the inflammatory process and the types of messenger molecules that are telling your body pain, that's a win-win. And that's what we're trying to do. We heard about PRP, and that's obviously peripheral blood that's centrifuged, and we can see that it has mostly water. We can pretty much all agree the bottom part, the red blood cells, are not our friend in any kind of injury or process, and because they have to be removed and create their own inflammation. But the rest of the products are still to be sorted out. We know those platelets have benefits, as Pierre was saying, and then their alpha and different granules that they have. The white blood cells, we're not so sure how much importance they have in every process, but that's certainly part of your buffy coat. And there's ways that you can kind of work around that with different techniques. But the bottom line is we decided that we wanted to deal more with the bone marrow, because we believe that's the source of all these good products that are coming out of into your blood, is through the bone marrow primarily. That's where all your white blood cells are made, all your platelets, so all your red blood cells too. But the mesenchymal stem cells work with the hematopoietic stem cells, and they've had this progressive evolution over like 500 million years. So with that concept, why not keep these cells all together and not just aspirate out what we call their daughter cells, which have value. There's mesenchymal stem cells in there, but they're very low percentages, like 0.002% of your total nucleated cells. So they're a very small population. And what we find is if you just use the traditional kits, and if you don't dip lower past that buffy coat into the red blood cell coat, we found that you're missing a lot of the mesenchymal stem cells that we're counting on to make the difference between PRP and what you obtain from your aspirates from your bone marrow, with the understanding that inside that marrow, these MSCs are producing all these exosomes, all these different types of factors that are typically trophic and in your benefit. So we want to keep them in, and they're in your plasma. So now we're kind of dialing down, how do we maximize the value of that product in your marrow that's there naturally. And within our suite, we use fluoroscopy. I don't have ultrasound, but this works great. We have a technique where you have to move the needle around many places in the posterior part of the ileum to capture fresh cells. And after that, we have our own sterile hood where we can process it mechanically and manually, obtain different segments of this product, so that we can continually to improve our biologic product. And our main goal is, as I said, going to the marrow, is to maximize these mesenchymal, oops, I almost said it, MSCs. I'm going to try not to say mesenchymal stem cells, but MSCs, because they have all these effects that are analgesic, they're neuroprotective, and they can regulate your immune system. So that's our goal. And what we did in our lab is we wanted to just answer some basic questions, because we were just treating people and it just seemed like shooting from the hip. And so we wanted to know, how many red cells, if we're dipping down into those red cells, how far should we go before we actually create a bigger problem? So we did a study on that, and there's too much in here to go through it since I'm limited in time. But we basically found if you go too many red cells, it really affects the stem cell MSC health. And so, we only want to keep that to about a hematocrit about 10%. So the other thing is, what about these platelets? The platelets that we see in your peripheral blood versus those that are in your marrow. Are they any different? Are there better platelets? And if you even want to get platelets, it seems that it's better to get your platelets right where they're made, where they're nascent, because they don't have a long longevity in your bloodstream where they're being contaminated. So this paper that we did showed that the platelets you obtain from your marrow are more pro-regenerative. And then even the anticoagulation or anticoagulant that you use may be a factor. And this is what we found by just using heparin, we were able to improve the bioactivity of these MSCs. So that's good information, and these were all published. And the last one that were just submitted for publication to the orthopedic journal. It's called Biologic Orthopedics, and it's more of the people in our space. And what we're looking at is how to maximize those true stem cells within their actual niche, where they are together with hematopoietic stem cells and their subpopulations, and also their extracellular matrix, because they all work together. So we wanted to make sure that was an opportunity, but we needed to study it and see if it actually was a benefit, and that's exactly what we found. So with that, these papers have been presented at high-level international meetings. We're very proud of that. And what we also want to do is say, well, how does this translate to patients? And since this section from SIMEG is about lower back pain and SI joints specifically, I wanted to kind of dial down into some of the literature, and instead of going through a lot of what I believe is not great literature, because there's no real good controls. There's just a lot of, there's not a lot of consistency in what is a PRP concentration, what is in your bone marrow. So how do you, if you don't know what you're giving someone, how do you measure the potential success or failure? So this standardization is missing. That's a very important thing. But this paper did do that. They did standardize, and it is a multi-center, and it wasn't randomized. It was open label, but they did show some very significant improvement of treating all comers with degenerative lumbar disc, facets, and SI joints. And they treated all of these tender areas with the same bone marrow aspirate concentrate. And you can see over a year, there was substantial improvement of their ODI, meeting the minimally clinically important difference, both for VAS and the ODI. So this kind of substantiates what we're seeing in our clinic. And I just wanted to recognize that paper. So what we're doing then is, as you can see, the PSIS is one of the higher sources for obtaining higher TNCs and CFUs, we call them. And those are basically these cells that we call MSCs that stick to the plastic. They're plastic adherent, and we can measure them in the lab and see what their colony look like in terms of the numbers. So on the right, you can see where you can put a needle into the cancellous bone, and you can aspirate, or you could obtain a bone biopsy, almost like a bone plug. And this bone plug, when you come out, is where those actual cells are making the marrow blood that's going into your systemic system. And that's where it's releasing not only your white cells, your red cells, your platelets, but also it's modulating, listening to the environment and sending out signaling molecules to help control inflammation and regulate your immune system. But it's kind of stuck there. So the idea is, why don't we just take it out of there? We'll mobilize it safely off of the bone. As you can see in this micrograph, the red is the bone. The blue is the glycan-rich matrix that your marrow lives in. That's where your HSCs are, your MSCs, all the subpopulations. So our process is, let's see if we can pull this off in some fashion. And we created a device that actually can do that. And we take that bone plug, we put it into this this disposable device, we have a benchtop unit that has a lot of variable speeds in terms of how the RPMs and the pressure and up and down motions, because it turns out that these cells are very sensitive, and you have to have some very, very controlled environments to not only bring them off the bone, but also to keep them viable. So this was quite a bit of trial and error, and that's why the flow cytometry and the whole lab was to prove that. And what we were able to see that we did find we had a unique cell population compared to BMAC. And this is really high level science, and I'm an orthopedic surgeon and I listen to the scientists and I appreciate everything they do, but the pictures speak a lot of words for me. We can see the BMACs, when you plate these, they're unique. They didn't really grow in these colonies. They just kind of spread out. And not only did they spread out, and I don't have all the data because I don't have all the time, but they had unique secretory profile that was much more anti-inflammatory and pro-healing, and they could survive in these toxic environments because they're in this 3D matrix. And this is one of the beauties of it over the BMAC, plus you have control. There's no real white cells, or essentially no white cells or red cells. So you can minimally manipulate this process where you have better control over each problem we're going to treat if you know you don't have to deal with white blood cells, which may or may not be your friend depending on the pathology. So this is what we believe is a significant advantage. Now, we've been fortunate to be in Fort Collins for a couple of reasons. One, we have Colorado State University in their vet school, and they have a translational medicine institute. So they're very much into regenerative medicine, but also a group up in Vail, the Stedman Philippon Research Institute, under Johnny Yurt and his colleagues, Celia Hambright, and others who have come along and joined us. And I'd like to give them a shout out, but we'll do that at the end. But this is a study we were fortunate enough to be involved in. I'm the principal investigator on human side to find the actual human donor for this study that I'm about to describe to you, with a nude rat that doesn't basically have a thymus and is immune privileged. So we can take one human donor and place it into all the rats without worrying about a variable. And this allows us to then add different controls and different arms of the study. And they're mostly interested in looking at senescent cells and their secretory profiles that are pro-inflammatory, that cause a lot of problems. And they use senolytic agents like fisetin. So their studies are ongoing, but they gave us a group of rats to perform our analysis of BMAX compared to controls and BMAC. With that, they have a lot of opportunity to study these further with micro-CT, histology, PCR. So this is an ongoing process, and I won't get into all the details because it's too much right at the moment, but I will show you where we are. So the way this model is they created an arthritis in the knee of the nude rat by cutting the medial meniscus and displacing it, then sewing the joint back up, and these animals run around in their cage for about 4 weeks, and then that creates the arthritis, and they have this as a validated type of model. Then after that, you are able to inject into the knee with the product that you're actually studying, whether it's the control or this case it's the BMAX, and then we can then analyze what's going on. After we looked at this donor and saw what their product was, we can see that BMAC and BMAX, there's a difference in their CFU analysis. You can see it, BMAX is much more of the blue there, which is more of the actual stem cells or MSCs. And with that, that validated what we were seeing. But then what's happening to these animals got really exciting, because you can see before injury, we have these three arms of the study. The control here is PBS, which is basically saline, BMAC, which we know, and BMAX is the technology I just explained to you. And then they run around for 4 weeks, and they test their sensitivity, and you can see it takes less of a push on their foot with a less pressure for them to react. And then after 4 weeks, we can see how the animals kind of go back to either baseline or in the case of BMAX, back to baseline, or like the control with saline didn't. So they weren't really improving with the saline, which we find is not just necessarily a negative control. It's really a control that tends to be beneficial when you look at human studies. So this is pretty powerful. Obviously, BMAC has its advantages as well, but you can see the clinical significance between them by the asterisks. The other way to look at it is a bend knee test. So you can take that animal and check their behavior when one of the handlers bends their knees, and you can see before the injury, you could bend their knee without much of a graded scale of pain behavior. Afterwards, you can see these graphs go way higher in terms of their pain that they have when they bend their knee. And then once you intervene 4 weeks later, you can see the different products from saline down to BMAX. We're finding, very significant improvement in their pain reaction. And this we actually carried out in 2 studies, one for 4 weeks, and then that looked so good we went out 8 weeks, and we can see it was maintained. The other issue is, although we don't have the micro CT or histology back, we do have what we call the knee diameter, where you can actually see that the knee is swollen, or what's the process. And we can see here that the knee diameter in the control is significantly higher than over time at 4 weeks and 8 weeks with the biologic products, especially BMAX with significance. So this is very exciting. And what this also does, it kind of helps us translate what we are seeing in the clinic, because this translational piece going back and forth between seeing your patients, seeing people get better. Why do they get better? How do we make that better? What do the animals tell us? I think this is where we need to go before we start doing large randomized controlled human studies, because we need to know what we're measuring, and we should be measuring the best product we can find. And I'm not saying we've totally found that best product, but that's our goal. So over this 9-year period, I've done about almost 600 patients, and a lot of these patients have multiple problems, which is nice. I can treat their shoulder, their knee, their SI joint, their lumbar disc. So they've had over 2,700 of these different sites that were treated. And you can see the outcomes. We're getting significant improvement. We're not curing people, but, most of them are very happy, and it's pretty consistent. What I usually say is 70% of people are about 70% better. And specifically, since this is about SI joint, we can inject into the joint. We can inject into the ligaments. And one of the things we know and found, that we know that anesthetics and contrast agents are not your friends in terms of MSC health. So I don't use contrast. I use my, tenderness is a very key part. But you can see the improvement of these SI specific pain patients that I had 18 of them, and substantial improvement that was fairly well maintained over a year. So I want to conclude by showing you, this is my left elbow. I took an x-ray of last week, and on the you can see when I had to switch to left-handed, I was much more careful, and I didn't overuse my joint. I didn't create the bad biology, and I didn't end up with a destroyed joint like I have on the right side. So I think this is going to be one of the beauties of sports medicine. I think we can prevent this. We want to show that in the rats at some point if we get a grant where we can actually inject BMAX or VMAC right after the injury, and see we can even prevent the arthritis from even beginning. And I want to thank my collaborators. Couldn't have done them without them. And specifically, Luke in my office, my right-hand man, and my son, Chris, who I couldn't have put this presentation together without him, but also the people at Spry and other collaborators, even Haruki from Japan, who's visiting at Spry and working, and Jacob Singer, who's been really helpful in helping us move our technology forward and understanding it better, and all through the list without having to name each one individually. Thank you.
Thanks, Jeff. That was absolutely phenomenal, and I think a nice compliment to the non-operative methods of therapy, which is at the forefront, and then go on to the biologics. I think that's great. Do you think that we're ready for a bone marrow aspirate with MSCs a randomized trial yet with for the SI joint?
I think, again, we're desperate, so we got to make the best of what we have, and then realize that next year it may be another, concoction. It may even be a mix of, stromal vascular fraction, micronized adipose tissue with, what we have, or lower white cells. And we certainly need the animal studies and the basic science before we pick that to have the best trial. But we got to start somewhere, and I think we're getting close. And I'd like to start this one. In fact, we have some Brazilian colleagues who want to start this in Brazil for us in humans.
It seems like and Dr. Kurosawa just wrote something in the comments about this too. We're still looking at even putting PRP in the SI joint, which is a brand new thing, and we don't have a lot of research or data. It's mostly anecdotal at this point, with some small studies. I think that Pierre showed with PRP. Do you think we're far enough along that we could actually do a comparative study of MSCs, PRP, prolotherapy, placebo?
Well, we have to standardize it and agree on, what this PRP is, what's the concentration. Do you do a lysate with it? Do you put calcium chloride in, or some type of agreement on that? And I think we could come up with something. And the reality is, we got to do something fairly soon. But they're very expensive, and a lot of these were done. I don't know if you've seen them, but they're not very positive in terms of PRP in a lot of these studies. But again, if they didn't standardize what the PRP was, and if you didn't do under fluoro or ultrasound and make sure you're in the joint, and you never know what you're going to get out of that study. So yes, it can be done, but needs a lot of forethought.